Hello, good morning everyone. My name is Kareem Seivwright and I'll be presenting on the literature review for sedation article 10. For the article title, it is Pediatric Conditions Associated with Compromised Airway Part 1 Congenital. The authors are Nicholas S. Wedge, Suher Baker, and Hedy O. Sedano. The name of the journal is Pediatric Dentistry Volume 31, Number 3. The journal impact factor has an H index of 65, which when compared to other journals, such as the Journal of American Dental Association, has an H index of 112, which basically explains that this journal had fewer citations. The date of publication is May-June 2009, and the type of article is a literature review. The major topic is congenital conditions and compromised airway. The main purpose is to aid in identifying congenital conditions and pathological states highly associated with airway complications in children and adolescents. Present literature shows that routine patient evaluation fails to find some of the conditions related to difficult airway management. Epidemiological studies have established that respiratory complications are the single most origin of pediatric anesthetic-related morbidity and mortality. A very detailed airway evaluation should also identify risk factors like snoring, sleep apnea, and premature birth. The review focused on syndromes and pathological conditions characterized by craniofacial airway anatomy predictive of airway compromise. The anatomical variation between the adult and pediatric airway also poses of great worry when one is trying to sedate a child. The lower airway of infants and children is more compliant and supported by less cartilage, leading to greater ease of obstruction by mucus, edema, pus, and aspiration contents. Anatomical variation. Within Table 1 of the literature review, anatomical factors contributing to difficult airway management shows anatomical features beside critical parameters predicting difficult airway management. There are quite a few of these anatomical features, but I'll only be going through a few of them. The trachea, for instance, if it has deviation or immobility, can prevent successful intubation in emergency situations. For body weight, children above the 95th percentile for body weight tend to have excess soft tissue, increased risk of obstruction, limited visualization of the airway, and limited head and neck mobility. For tonsillar tissue, greater than 50% of the oropharyngeal area occupied by hypertrophied tonsillar tissue increases chances of obstruction, impairs adequate ventilation, and prevents visual access of the airway in emergency situations. For the tongue, macroglossia prevents airway visualization. There can be tongue displacement. This thereby increases the likelihood of obstruction as well. In Table 2, it shows anatomic and physiological differences between the pediatric and adult airway. For instance, the tongue is larger and bulky relative to the size of the oral cavity for children, as opposed to adult, where it is proportional to the size of the oral cavity. The epiglottis in children is longer, narrower, and stiffer, U or V-shaped, as opposed to adult, which is flat and more flexible. The larynx of the child is funnel-shaped, pliable cartilage, narrowest diameter below the glottis at the cricoid level. For the adult, it is cylindrical in shape, stiff cartilage, narrowest diameter at the vocal cords. These differences play a key role when sedating a child versus an adult. Also interestingly to note, the heart rate is 80 to 130 beats per minute for a child as opposed to an adult. This can cause serious issues if the child's airway is obstructed, meaning that the myocardium of the child will receive less oxygen and therefore cannot beat fast enough to keep up the blood flow of the child as opposed to an adult, which requires less beats per minute. Due to the fragile nature of these patients, it is recommended that most large-scale treatment requiring pharmacological management be done in a controlled inpatient setting to guarantee patient safety and to prevent loss of the airway. Oral sedation is strongly cautioned in these patients, as airway obstruction and changes in the respiratory function must be found quickly and reserved to prevent hyperventilation and rapid desaturation. Interestingly to note, inpatient rehab versus outpatient rehab. The reason why inpatient rehab is so key for these patients is because in an inpatient situation, they are within the facility as opposed to an outpatient rehab where they are only there for a short period of time and not admitted. There's higher success rate with inpatient rehab versus outpatient rehab. Thus, if any emergency were to take place, they can be treated by experts and professionals much quicker and they can be monitored around the clock. Congenital conditions. There are quite a few congenital conditions mentioned throughout the literature review, but for this purpose I'll only be going through 3, mainly because these 3 have the highest incidence and prevalence. Down syndrome trisomy 21 normally presents with a narrow nasopharynx, large tonsils and adenoids, macroglossia, poorly developed bridge of the nose, small subglottic area, microcephaly, cervical spine abnormalities, altantoxial subluxation, and broad short neck as well as obesity. Cretinism, also known as congenital hypothyroidism, presents with macroglossia, compression of the trachea, deviation of the larynx or trachea, laryngeal nerve palsy, or paradoxical vocal cord motion. Von Recklinghausen disease, also known as neurofibromatosis, can present with tumors that may occur in the larynx and right ventricle outflow tract, cervical spine abnormality, tongue lesions, and macroglossia. Here in this picture, one can see a child with Down syndrome. You can note the large tongue showing macroglossia that can obstruct the airway and pose difficulty. Here we see a child with cretinism, and also to the right of this child, one can see the vocal cords. The right vocal cord is normal in that image, but the left vocal cord is paralyzed. This can be better appreciated when the vocal cords are closed. The right vocal cord covers over more as opposed to the left vocal cord, which is a complication that can present with cretinism. In a child with neurofibromatosis, one can see the lesions present throughout the face on the orbit. Intraorally, they can also present at times with tumors present above the vocal cords, which can cause serious obstruction as seen in the image to the right. Many of the patients discussed in this review show significant cognitive deficits in addition to abnormal airway anatomy. Patients with greater cooperative skills, as in Down syndrome, may require milder sedation levels to finish a given procedure than patients requiring both behavior guidance as well as advanced airway management. The use of anaxylosis in patients with anatomical features predisposing to airway compromise can be an acceptable alternative to general anesthesia if careful patient selection is upheld. When careful attention is given to anatomic variability and understanding of the associated airway implications is achieved, a clinician of any discipline can proceed with confidence and in the best interest of their patients. A team approach that depends on the effective communication between clinicians will ensure safety and prevent complications during and after treatment. For the assessment of the article in terms of level of evidence, as we can see here in the hierarchy, of evidence in the diagram. Based on the hierarchy of evidence, this article is at level 5 in terms of evidence. This is due to it being a literature review. It does not provide any contrast between any data or any randomized clinical controlled trials or case control studies. It is mainly a compilation of expert opinions and viewpoints on the topic at hand. In conclusion, in assessment of the article, while the article does provide a guide as to what to expect in terms of complications and stressing the importance of evaluating pediatric patients, especially those with craniofacial abnormalities, it is highly susceptible to bias due to no randomized clinical control trials being done. The lack of statistical evidence to support the concerns and claims of the literature would make it not ideal to base treatment guidelines from it alone. Other research would have to be taken into consideration. That is the end of my presentation. These are my references, and if there are any questions, thank you.